Good morning, everyone. I think we'll go ahead and get started here. So it's my pleasure to introduce Ticiana Leal today. Ticiana is originally from Brazil, and she did her medical training at Federal University of Sierra. Did I say that right? Okay. She then completed her residency at Weiss Memorial Hospital in Chicago, then did a geriatrics fellowship at University of Illinois before coming up here. She did her medical oncology fellowship here at University of Wisconsin, and she's been on faculty with us since 2009. She initially came on as a clinical assistant professor, and then probably about how many years ago was it? 2012, she track switched into the CHS track. So Ticiana's focus is on lung cancer, and specifically on immunotherapy of lung cancer, which is really getting increasing national recognition for. She has grant funding from a number of sources, including a pilot grant from the Cancer Center. She has more than 13 peer-reviewed publications, almost 30 abstracts, and has spoke internationally on this topic throughout the US and also internationally. Internally, she leads the Thoracic Oncology Working Group, our disease-orientated team. Nationally, she's a member of the Eastern Cooperative Group Lung Cancer Core Committee, and she was recently appointed as co-chair of the Big Ten Lung Cancer Working Group. So she's going to talk to us about, I think, a very important topic of immunotherapy, because I think even for internal medicine people, the complications of these drugs are something that we're going to increasingly need to know about. So, thanks.
Okay, thank you very much for the introduction. Thank you for being here today. And I will talk to you about immunotherapy and lung cancer in general. And the objectives of this talk, we're going to start out by briefly reviewing the mechanism of action of PD-1, PD-L1 inhibitors. We'll also talk about the advances that these agents have brought to patients with advanced non-small cell lung cancer, and then talk about the side effects. So hopefully I'll prove to you that the benefits are worth the potential risks and side effects. And then lastly, I think the most important thing that I think is relevant to all of us is that, a lot of these adverse side effects that we're seeing are going to be managed by all of the subspecialties, depending on the severity of these events. So this is just a summarized slide of the really complex multi-process steps in immune regulation and immune activation in the set of advanced cancer. So over here what we're seeing is it all should start with the APC, or the antigen presenting cell, which is usually a dendritic cell or macrophage in the microenvironment. And what ultimately happens is that this cell will interact with the tumor cell via the MHC class molecule. This cell will present the antigen, which is basically at this point a peptide or a protein, to the T cells. But what happens in the priming phase is that these T cells also have, and this is not shown here in a very complex way, but the CTLA-4 receptor is basically a brake on the immune system. So in the priming phase, what usually happens is, to kind of keep the checks and balances of the immune systems, a lot of times that CTLA-4 receptor is going to be activated. And when that happens, you have a brake on that immune response. And so what the cancer cells do at this stage is they actually engage with the CTLA-4 and also engage with the other receptor called PD-1, which is another brake on the immune system, and put a brake on that immune response. So what these agents are doing, both here at the CTLA-4 receptor and then here at the PD-1 receptor, is they're basically blocking those two receptors and then allowing the immune system to be more efficiently activated. In addition, we now have agents that target PD-L1. So PD-L1 is the ligand that connects to the PD-1 receptor. And so agents that actually block the ligand have also shown to be effective. And as you can see here, the tumor cell will actually express this PD-L1 and PD-L2, and this is a way that it can basically stay under the immune radar and then continue to grow, metastasize, and spread. But as I said, that was a very simplified picture. We know that there are multiple co-stimulatory and inhibitory interactions that regulate T cell responses. We do think that PD-L1, PD-L2, and the PD-1 pathway is probably the predominant most important immune checkpoint. However, we also know that there are other important, not only stimulatory but also inhibitory. And this is very important because this has to do with how we move into drug development and try to target other ways to improve that immune response. This is the timeline of how we've developed these agents in advanced non-small cell lung cancer. And I can tell you that this timeline has really been accelerated, and it's been really incredible to, even in my own career, be able to see these drugs move from phase 1 to now actually being routine and standard of care for our patients. But as you can see here, we have 3 agents that are currently approved. We'll talk about them in more detail. Nivolumab is a PD-1 blocker. Pembrolizumab is another PD-1 blocker, so at the receptor level. And then we have atezolizumab, which blocks the PD-L1 ligand, which is the newest kid on the block, not so new anymore. So here we have in 2008, this was the first time we actually investigated nivolumab in a phase 1 trial, so first in human, in multiple solid tumors, including advanced non-small cell lung cancer. And as you can see here, in 2012, we actually moved on to phase 3. And these were the 2 landmark trials, Checkmate 17 and 57, that were initiated in 2012. And then pembrolizumab was also initiated in a phase 1 at that same time. Moving on to 2015, we actually had approval of nivolumab, so the first PD-1 receptor blocker that was actually approved in the second-line setting in non-small cell lung cancer. And then in 2015, we had approval of pembrolizumab. So very rapid development, very rapid approval. Pembrolizumab was actually approved based on the phase 1 trial and subsequently established the benefits in phase 3. And then 2016, we had approval of atezolizumab. In 2017, pembrolizumab now moves to frontline settings, so as the first treatment for patients with advanced non-small cell lung cancer. And then most recently, also the combination of pembrolizumab with chemotherapy. And this timeline keeps moving because we recently had, just last month, presentation of durvalumab, a PD-L1, which has not yet been FDA approved, but showing benefit in stage 3 patients. So moving on to the nivolumab phase 3 trial, I'll briefly summarize these 2 trials. Checkmate 17 investigated nivolumab in the squamous population, and then Checkmate 57 in the non-squamous population. So both trials had very similar designs. This is a phase 3 trial comparing nivolumab, which was established dose at that phase 1 trial that I told you about, in comparison to docetaxel, which at the time was our standard second-line chemotherapy. So these are patients that have had advanced non-small cell cancer diagnosis. They've had their initial chemotherapy regimen, which is usually a combination of carboplatin with another agent, and now they're moving on to second line. These patients were randomized 1-to-1. The primary endpoint of this study was overall survival. And here is the overall survival result of Checkmate 17 in the squamous cell population. As you can see here by the survival curves, there is a significant improvement in the 12-month overall survival rate of 42% versus 24% with nivolumab. So this study established the benefit of nivolumab in patients with advanced non-small cell lung cancer with the squamous histology. Another very interesting feature of these classes of drugs is the fact that that survival is actually sustained. And we can see here that at the 18-month survival, we can continue to see that survival benefit. At the 2-year update, that survival benefit is also continued to be maintained. This is the study in the non-squamous population, and it showed similar results. As you can see here, again, we have a significant benefit of nivolumab compared to docetaxel with an improved overall survival rate. And this is the phase 1b updated results. So this is pretty incredible to have a 5-year update on a phase 1 trial. You know, historically, we've thought that a very small percentage of patients actually benefit from phase 1 trials, but they actually looked at 5-year survival, and we still saw patients who were at 5 years alive, and most of them were actually free of progression at the time of this updated analysis. And we have a 5-year overall survival rate of 16%. And yes, you can say this is probably still too low and we need to do better, but historically the 5-year overall survival rate for advanced non-small cell lung cancer is 4%. So this is, to us in the field and to our patients, a significant benefit. This is KEYNOTE-10, so it's the next phase 3 study that was done with pembrolizumab. And they took kind of a different approach. They really focused on the immune biomarker called PD-L1. So remember we talked about how PD-L1 is expressed on the tumor cells. So they measured through immunohistochemistry the PD-L1 expression on the tumor cells. And they used 1% or greater as a cutoff for study entry. This study, again, is a randomized study. This was a phase 2-3, so they were still investigating the optimal dose of pembrolizumab as compared to docetaxel. And the endpoints of this study are looking at 2 different PD-L1 expression cutoffs, and the primary endpoint is progression-free survival as well as overall survival. And as you can see here, this study was also a positive study. On this side, we're looking at the patients that had a PD-L1 expression of 50% or greater, and there is a significant survival benefit of pembrolizumab at the 2 doses as compared to docetaxel. This benefit was also seen in patients who had PD-L1 expression of 1% or greater. So this, again, established the benefit of pembrolizumab, not only in the 50% or greater cohort, but also in the 1% or greater. So for pembrolizumab, the development has really been associated with this PD-L1 biomarker. Progression-free survival was positive in the patients with 50% or greater PD-L1 expression. It was not seen in the patients with the 1% or greater cutoff. And interestingly, that was also similarly seen with Nivolumab, and perhaps, PFS is not the optimal endpoint to look at for these patients receiving immunotherapy. So this is the phase 3 OAK study. This one established the benefit of atezolizumab, the PD-L1 inhibitor that targets the ligand. This is similar study design. They also looked at patients that had PD-L1 expression. But patients with PD-L1 negative status were also included in this study. This was a study that randomized patients 1-to-1 to atezolizumab versus docetaxel. The primary endpoint of this study is overall survival in the intent-to-treat population. This was a positive study, again demonstrating the benefit of PD-L1 inhibitor atezolizumab in advanced non-small cell lung cancer. Although PD-L1 was not a necessary eligibility to enter onto this study, there was a correlation with overall survival by PD-L1 expression. With atezolizumab, the measure of PD-L1 expression is slightly different. They are using a different antibody, and they're also measuring not only PD-L1 expression on the tumor, but also on the immune infiltrating cells. So that's why you see 2 components here of TC3 or IC3. But what we can see is the greater the PD-L1 expression, you see an increasing overall survival benefit. This is also, again, looking at the progression-free survival, and you can also see here the progression-free survival according to the PD-L1 expression. Objective response rate was also a measure that was improved with atezolizumab compared to docetaxel. And most importantly, what we're seeing across the board on all of these studies is that duration of response. So if patients obtain a response from these agents, this duration of response is really quite remarkable and very different to what we're accustomed to seeing with chemotherapy. This is a meta-analysis that I just wanted to point out because I think there's a lot of debate on whether these agents have activity in patients with actionable mutations. So we have a subgroup of patients in advanced non-small cell lung cancers that have genetic mutations such as EGFR and ALK and ROS1, an increasing number of targets. But in the initial studies, what we're seeing, limited data so far, is that perhaps immunotherapy is not as effective as with other patients if you have a target or an actionable mutation. And this meta-analysis actually looked at the 3 main studies investigating these agents and demonstrated that although we did see a benefit of PD-1, PD-L1 inhibitor in patients with advanced non-small cell lung cancer as compared to docetaxel, if patients had a sensitizing EGFR mutation, as you can see here, it actually favored towards docetaxel. So there was no survival benefit in patients with EGFR mutation in advanced non-small cell lung cancer. So this is a summary of the survival curves So I hope that I've been able to prove to you that these agents really do have a significant benefit in advanced non-small cell lung cancer, multiple endpoints across multiple trials. Thousands of patients have been treated with these agents. Moving on to the frontline setting. So now these are patients that have not received any treatment for their new diagnosis of advanced non-small cell lung cancer. This study is called KEYNOTE 24, and this is a study that was investigating pembrolizumab in the frontline setting in patients with that PD-L1 expression of 50% or greater. And as you can see here, patients with EGFR mutations or ALK translocations, those patients with that genetic mutation are excluded from this trial. This study randomized patients 1-to-1 to pembrolizumab as a single agent compared to chemotherapy, which is a platinum-based doublet. This study did allow crossover to pembrolizumab upon progression if patients met eligibility criteria for crossover. Primary endpoint of this study is progression-free survival. Secondary endpoints are overall survival, response rate, and safety. So I'll summarize the data showing that this study was an overwhelmingly positive study. It showed a significant benefit with regards to progression-free survival in patients with advanced non-small cell lung cancer on the pembrolizumab arm. As you can see here, the 6-month PFS was 62 versus 50%. At 12 months, 48 versus 15%. And again, a significant overall survival benefit. You can see here the 12-month overall survival is 70 versus 54. In this study, actually, they requested that patients that were on chemotherapy at that point actually crossed over to pembrolizumab because of this overwhelmingly positive result. In addition, we also saw improved response rate in these patients, so 45% versus 28%. And again, looking at that duration of response, we're seeing a significant duration of that response compared to chemotherapy. This is the most recent study in the frontline setting, KEYNOTE 21. This was actually a multi-cohort study. I'll focus on cohort G, which is the cohort that looks at patients with advanced non-small cell lung cancer with the non-squamous histology. So the chemotherapy that we generally use for this group of patients is carboplatin pemetrexed. So what they did here, this is a phase 2 study, so this is actually a smaller study, but they randomized patients to pembrolizumab in combination with chemotherapy, so carboplatin pemetrexed. And then the comparison arm was the standard of care of carboplatin pemetrexed. And patients were enrolled independent of PD-L1 expression. The primary endpoint of this study is overall response rate. And as you can see here, the overall response rate was significantly improved with the combination chemotherapy plus pembrolizumab versus chemotherapy alone. And again, the duration of response is quite remarkable. There was a clear progression-free survival benefit, as you can see here. The pembro plus chemo arm had a median PFS of 13 months and chemo alone of 8.9 months. However, this study has not shown a survival benefit for those two arms. This actually led to approval of the FDA of this combination therapy, and the phase 3 study has actually completed accrual, but the results have not read out yet. I'll just summarize the toxicity data, and we'll talk a little bit more about that, but I wanted to sort of show you that when you add chemotherapy to immunotherapy, you're definitely going to see more treatment-related side effects. You see more of the grade 3-4, which are the severe severe toxicity, but in terms of actually leading to patient deaths or treatment discontinuation, that was not significantly different. And then just real quick, a slide about the stage 3, because this just came out last month. This was presented at a major meeting and then published on the same day, looking at durvalumab. This is not yet approved by the FDA. This is another PD-L1 inhibitor, and this agent was actually studied in patients with stage 3 lung cancer. So these are patients with what we call locally advanced non-small cell lung cancer. They don't have metastatic disease to other organs, and the usual treatment is concurrent chemotherapy in combination with radiation. So these patients received concurrent chemoradiation, and then they were randomized to durvalumab versus placebo for a year. And this study showed a significant benefit of durvalumab over placebo, and the median PFS was 16.8 months versus 5.6 months. And it's been many years since we've seen anything that has provided any additional benefit to this stage 3 population. So this will likely lead to approval of the first immune checkpoint inhibitor in the stage 3 setting. And so what we're moving on now is to looking at novel strategies. So we've established the benefit of PD-1, PD-L1 inhibitors. However, we also know that there is a subset of patients that don't respond at all, and perhaps some patients that probably shouldn't be getting single-agent immunotherapy like we talked about the EGFR and the ALK population. So what are the strategies moving forward? And remember all those co-stimulatories and inhibitory molecules that you saw. So there are multiple ongoing studies looking at the CTLA-4 antibody. So Ipilimumab is established in melanoma. So far in non-small cell lung cancer, still investigational. And as we saw here, we're also combining it with chemotherapy. There's a lot of studies ongoing about how to incorporate radiation to immunotherapy and how perhaps radiation can stimulate the immune system and improve the responses with immunotherapy. And then there are multiple other checkpoint inhibitors that we're currently investigating in earlier phase studies, and also vaccines. Some of our efforts here have been looking at combination strategies. So this study is a study that is ongoing here at University of Wisconsin, where patients that have actually progressed on PD-1, PD-L1 agents, we're trying to understand the mechanism of resistance, and can we still salvage these patients and incorporate other agents to overcome these mechanisms of resistance. So this study is looking at sitravatinib. This is a phase 2 study. And sitravatinib actually hits multiple tyrosine kinase inhibitors. We think the main mechanism of action of how it can synergize with immunotherapy is here by hitting these TAM receptors, because this is a way to improve the immunosuppressive environment at the level of the macrophages. And so basically what we've seen so far is early signs of clinical activity in patients who have progressed following prior immunotherapy. Some of these patients had not received prior benefit from Nivolumab or atezolizumab or pembrolizumab. We've actually seen some interesting partial responses. And the combination so far has been manageable toxicities, and this study is ongoing. Another study that will be opening up here soon in collaboration with the Radiation Oncology department. So Michael Bassetti is the main PI on this study. This is an investigator-initiated trial, and it's really looking at a subgroup of patients with oligometastatic non-small cell lung cancer who have limited disease spread of their lung cancer, and incorporating aggressive local therapy with stereotactic body radiation to all sites of oligometastatic non-small cell lung cancer, concurrently with combination immunotherapy. So we heard about durvalumab, the PD-L1 inhibitor, in combination with tremelimumab, which is a CTLA-4 inhibitor. So let's look at toxicities. So we showed the benefits. Now, on the flip side, we have to think about the cost. We have to think about, the side effects and how it's impacting our patients in their day-to-day lives. So this is a summary, just looking across trials in the second and third line setting, and looking at related grade 3 to 5 adverse events. And 3 to 5 adverse events are severe, sometimes life-threatening events when you get to grade 5, and then can lead to death. So in the atezolizumab study, we see 15%, nivolumab 8%, and 8 to 11%, and then KEYNOTE 10, 13 to 16%. As you can see here, the discontinuation rate is actually relatively low. And, as a thoracic oncologist, certainly pneumonitis is something that we worry about quite a bit. And we have seen, low rates of grade 3 to 5 events related to pneumonitis, but we also have seen deaths related to this if we don't intervene early. So there was a meta-analysis that was presented looking at, is there a difference in toxicity between PD-1 and PD-L1 inhibitors? So this meta-analysis looked at all the ongoing trials, including trials looking at durvalumab and avelumab and other agents that are still in development. And the overall rate of AEs between PD-1 inhibitors and PD-L1 inhibitors are about the same, including the more severe events. And then the most common events were fatigue, diarrhea, rash. And again, we're not seeing a real big difference between these two classes of agents. Looking at the immune-related adverse events, which we'll focus on more, we again don't really see a significant difference looking at PD-1, PD-L1 inhibitors. Hypothyroidism was certainly the most common immune-related AE that was reported. And then pneumonitis, there seems to be a difference in terms of PD-1 inhibitors versus PD-L1 inhibitors. And the thought is that when you target PD-L1, you spare PD-L2, and perhaps that's a more important mechanism for pneumonitis in patients that receive these agents. And then again, no difference in colitis. This is adverse event rate by drug. So again, similar adverse events. And then let's move on to the immune-related AEs, which I think is what we really need to focus on, because these are the ones that, although rare, can really lead to life-threatening consequences. One other caveat is, again, we talked about how in lung cancer, single agent is approved, but we do have patients receiving combination therapy here at UW with melanoma diagnosis, but also because these agents are being developed in combination across a variety of different tumor types. So these might be patients that might be coming into the ER. They might be coming to you, to your primary care visit to discuss other things, and you may be able to pick up on some of these things if they're on these agents. So the most common adverse events that we generally see are fatigue, rash, cough, diarrhea, or constipation. Majority of the events are pretty mild, and when you compare it to chemotherapy, we're definitely seeing that these patients are having less side effect. But there can be inflammatory events that are related to excessive activation of the immune system or excessive or dysregulated activation of those T cells at the effector phase. And so we really have seen all of these, or if you treat enough patients, you will see all of these. But we commonly see, as we talked about, the endocrine abnormalities are the most common, and certainly hypothyroidism is the most common manifestation that we see. But we've also seen patients with adrenal insufficiency that's kind of hard to pick up. So patients with unexplained fatigue, think about adrenal insufficiency. Pneumonitis, we talked about that. And then hepatitis, colitis is very important. And then myocarditis. And the reason why I point out myocarditis is because although, again, very rare, supposed to be pretty rare with single agent, we've actually seen 6 cases here at UW with single agent therapy in the majority of the patients. And unfortunately, some of these cases were fatal with fulminant myocarditis. So the immune-related AEs are the most common adverse side effects that are associated with these agents. And in most cases, these are manageable. But there are patients that they can experience these effects really at any point during therapy. So we've tried to plot out, is colitis more likely to happen early on? Is pneumonitis going to happen kind of in the middle of treatment? When does the rash or dermatitis happen? And there are studies showing that there is a peak incidence, and we see that GI toxicities seem to kind of peak earlier on. But the bottom line is it can happen at any point during the treatment. And it can even happen after discontinuation of therapy. So even after your patient stops these treatments, you do have to keep an eye on them for any of these events for the next few months. And one of the most important things that we've learned through these clinical trials and through clinical practice is that early recognition is critical. There seems to be a point that if you wait too long, you might not be able to stop that process despite increasing immunosuppression. So early recognition is critical, and I think that involves all of us. And so prompt evaluation, prompt initiation of treatment, and getting those subspecialists involved in the more severe events, because we may need to be doing additional procedures or providing additional aggressive supportive care to get these patients through this toxicity. So treatment of moderate or severe immune-related events usually, and for the majority of cases, require that you stop the immune checkpoint inhibitor and use corticosteroid. One of the things that we've done in clinical trials, which I think actually really helps in clinical practice, is grading the toxicity. So we talk about the CTCAE, where we have sort of an outline of what constitutes mild, moderate, and severe. And so, for me to think about, is this patient having a moderate toxicity or severe toxicity, I really have to go back and look at that grading. And depending on what kind of toxicity, the moderate is a little bit different. And when to start steroids may be a little bit different as well. So treatment is based upon the severity, and it's also based on what kind of toxicity. So for patients that have grade 2, which is considered moderate immune-related adverse event, you should hold the checkpoint inhibitor. In some cases, you can You can withhold the steroids, for example, if patients have a grade 2 rash, which means basically that the rash involves 1 to 30% of their body surface area. A lot of times you can treat them with topical corticosteroids, continue the immune checkpoint inhibitor, and just watch them closely. A lot of times we manage these patients ourselves, and we don't really refer them to dermatology. But there are situations where a grade 2 toxicity can actually escalate very quickly to a grade 3, for example, with pneumonitis. So if a patient has a grade 2 pneumonitis, this is a patient that we're actually going to withhold the immune checkpoint inhibitor and aggressively start them on corticosteroids right away and not wait. Same thing for hepatitis. If a patient develops elevation in their AST, ALT, and it gets into that grade 2 level, which is 5 to 20 times the upper limit of normal in that more moderate to severe range, these are patients that we're going to start them on corticosteroids right away and not wait until they develop symptoms of hepatic failure. So for patients that have grade 3 or 4 immune-related adverse events, treatment will be permanently discontinued. There are a few exceptions to that, but for the majority of patients, these are patients that we generally don't re-challenge. And this is a question that comes up quite a bit, because for patients who develop severe toxicities, that we can actually manage that toxicity and have that patient get better. We'll talk a little bit about what it looks like for them in the future in terms of what happens to their tumor response and how did they do after this toxicity. So in general, high doses of corticosteroids should be given. And for more severe symptoms, you can start at prednisone 2 milligrams per kilogram per day. And one important thing about how to manage these toxicities is the taper needs to be very slow. So you shouldn't taper the steroids for a shorter period. It really is, their patient's going to be on steroids for about 4 weeks or maybe a little bit longer. And the reason for that is there will be rebound of some of these immune-related events, and sometimes that rebound can be more difficult to manage. So the impact of immune suppression for management of immune-related adverse events. So the studies that have been done have been mainly in melanoma patients. They went back and looked, okay, what if my patient has an immune adverse-related event, and I have to start them on immune suppression? The biggest concern for patients and for providers was, will I lose that benefit? Will I lose the response? And the answer is no. The studies have shown that even in patients who require high-dose steroids for management of immune-related adverse event, their survival is not affected by having to be on immune suppression, and they don't lose their response. So a lot of these patients that actually have grade 3 to 5 toxicities, they're maintaining their response, and that response is durable. So one of the things that I get asked a lot is, well, should I restart my patient on immune checkpoint inhibitor now that they're off their steroids and doing well? If they're responding, you shouldn't restart. So the risk of re-challenging them and getting another immune adverse event or other immune adverse events in a patient who's actually maintaining their response does not justify restarting. The biggest challenge is, okay, what do I do upon progression? And I think, studies are ongoing about the risks and benefits of re-challenging. A lot of the studies are showing that there's as high as a 40 to 50% recurrence of grade 3, 5 events when you re-challenge. So I think you have to really individualize that and discuss with that patient what the risks are going to be. So I thought I'd move on to doing more of a case-based discussion, only because if there are people that have had some experiences and you'd want to discuss some of these experiences, we can review some of those cases. It might be more beneficial. So this one perhaps is more for the oncology group, but this is a 58-year-old female who's a never smoker with bilateral lung metastasis, and the biopsy shows adenocarcinoma. We've done molecular testing with a broad panel, and it shows an EGFR sensitizing mutation. We've also done PD-L1 expression staining on the tumor cells using the antibody that's approved for pembrolizumab, because this is the only one approved in the frontline setting, and this patient has never been treated. What would you recommend? Any show of hands? Any oncology fellows? Very good. Okay, that was easy. So, yes, you guys are correct. So for patients with an EGFR sensitizing mutation who have never received any treatment for the advanced non-small cell lung cancer, there are 4 options there. Those are all the 2, 3, and 4 would potentially be options for patients with advanced non-small cell lung cancer. We reviewed how pembrolizumab can be used for patients with advanced non-small cell lung cancer with high PD-L1 expression, pembrolizumab plus chemotherapy for the non-squamous population independent of PD-L1 expression in the front line, and then chemotherapy. This combination strategy here is for patients who do not have high PD-L1 expression and do not have an EGFR or ALK mutation. So for patients with an actionable mutation, the take-home message is you treat them with a targeted agent and not with immunotherapy. And immunotherapy right now at this point is of unknown benefit for this population and should really be reserved sort of as a last line of therapy, even beyond chemotherapy. Here's a second case. And of course, I have to show a CT scan of the chest, so you guys probably will know what's going on. So this is a 70-year-old female. This is a former smoker from our practice with non-small cell lung cancer. This patient was treated with an anti-PD-1 antibody and had a response. And then she presented with increasing cough, shortness of breath, and hypoxia to the emergency room. And what is your management recommendation? And this happens frequently in the ER. So the ER is a common, port of entry for these patients. What would you do? Very good, Nan. That is correct. So this is a case of severe pneumonitis. So whenever there's hypoxia, that automatically puts them into the grade 3 category. So if patients have severe symptomatic pneumonitis with hypoxia, this automatically means a hospital admission for intravenous steroids. And we frequently use methylprednisolone. And this is a patient who, within the next 24 to 48 hours, we should probably see a response in terms of improvement in their symptoms and improvement in their hypoxia. So one of the things that's really important to sort of remember is that if patients are not responding to that initial immunosuppression within 48 hours, especially with symptomatic severe pneumonitis, this is a patient that we're going to call refractory to corticosteroids. And this is the patient that we're going to start on additional immunosuppression. So likely, we'd be consulting pulmonary for bronchoscopy to do BAL. We always want to exclude infection as a potential confounder. I mean, these are patients that, have COPD, have other comorbidities, are certainly at risk for viral and bacterial infections. And so we always want to exclude that this patient is not having an infection because of the implications of how to manage this patient in terms of additional immunosuppression, not being able to continue their treatment that they were benefiting from. So frequently we'll ask pulmonary, can you do a bronchoscopy? Well, we want to see those cultures and we want to see a biopsy. Could it be cancer progression? Could it be lymphangitic carcinomatosis? So there is a differential that we're working on. The message is start the high-dose steroids, but do the workup in parallel so that you can be sure that your diagnosis is correct. So in patients who have pneumonitis and we do a bronchoscopy, a lot of times what we're seeing is lymphocytic infiltrates. And so although it's not completely diagnostic of pneumonitis, when you put everything together, the clinical picture, the radiographic findings, as well as those findings on bronchoscopy, it'll strengthen our diagnosis and kind of confirm that we're on the right path, especially if these patients become corticosteroid refractory. The next step would then be starting additional immunosuppression. And so one of the things that's evolving for patients with refractory to corticosteroid treatment is what additional immunosuppression should you be using? And so we are actually extrapolating from other disease types and other problems that patients have had. And so one of the things that we really need to study is how to manage patients that don't respond to steroids. So a lot of times we've used infliximab, and this is mainly from the GI literature, or we've also used mycophenolate. And then in patients with myocarditis, one of the things that we've talked a lot about is, what agent should we be using? Perhaps infliximab in patients with grade 3 or 4 heart failure, infliximab might be an agent that should not be used. And so there are a lot of studies trying to sort of not only identify these toxicities early, but also how do we use the immunosuppression that's going to be most appropriate for that type of toxicity. So a lot of talk about using tacrolimus in myocarditis, or perhaps the IV anti-thymocyte globulin. A third case study that I wanted to share with you is a patient, again, from our practice. This is a 70-year-old female who is an active smoker, and she was diagnosed with stage 4 squamous cell carcinoma of the left hilum. This is her PET scan. As you can see here, she has a central left hilar mass with collapse of the left upper lung. And she also had adrenal metastasis as well. And she also had liver metastasis. She was actually enrolled on a clinical trial here, and she was randomized. This was a phase 3 study looking at PD-L1 inhibitor plus CTLA-4 inhibitor. So she actually got randomized to combination therapy. She received 4 cycles of therapy, and she obtained a near complete response after 2 cycles, which basically for her meant she had complete resolution of her liver mets, complete resolution of the adrenal mets, and I could still see a 5 millimeter soft tissue density at her hilum. So this patient actually developed grade 3 diarrhea, which at the time actually led to a hospital admission. So she had, 6 to 7 episodes of diarrhea above her baseline. She also at the time was found to have grade 2 hepatitis based on her AST and ALT, and this was in September of 2016. She actually got admitted, responded well to prednisone, and then was subsequently discharged home. And I'll give you her course over the next few months, because I think this is also really important to note, is that over the next few months, as we're observing her off therapy, she actually developed hypothyroidism as another immune-related adverse event. And she ultimately required starting levothyroxine for her immune hypothyroidism. And then subsequently in December of 2016, so this is about 3 months after she discontinued therapy, she came back from Mexico after a vacation, and she said, I feel really strange. My legs are feeling really weak, and I feel very tired. And we scanned her, no evidence of any cancer. All her endocrine tests looked pretty good. We actually noted that her sodium was 125 to 130, but overall not too different than before. And she ultimately underwent an extensive workup. We referred her to neurology. We did paraneoplastic disorder panel. We looked for myopathy. We looked for evidence of neuritis or any kind of neurologic disorder, and actually didn't find anything in that regard. But this was a patient that was previously functional, is now really having a decline in her overall ability to function at home and be independent because of this unexplained fatigue and bilateral leg weakness. So what is the next best step? And this is a true story. So these were things that were discussed. So number 1, no further workup is needed. The patient doesn't have any evidence of cancer. Number 2, this is likely deconditioning, and patients should be referred to physical therapy and rehab. Number 3, additional workup is recommended. What would you order? And number 4, hospice referral. Given her functional decline, she's not a candidate for any additional treatment if her cancer progresses. Very good. Excellent. You guys are awesome. So let me go back and I'll tell you what actually happened to her. So this patient, while she was having the workup, actually had an episode where she was found down at home. We admitted to the hospital. She had seen me the week before and was kind of undergoing an outpatient workup. The week before, her scans looked fantastic. She got admitted, had rhabdo, had sort of this new infiltrate in her left upper lobe. And so everybody was thinking, oh, she's progressing. She actually had a really difficult course in the hospital with sepsis, had atrial arrhythmias, required sort of a rapid response in the hospital, and was very, very ill until we discovered that, in fact, she had adrenal insufficiency. And so obviously we treated her infection, we treated her arrhythmia in the hospital, and then started her on hormone replacement for her adrenal insufficiency, and literally within a week, she was like a new person and back to her old self again. So that was pretty incredible to see. But I think it's a really good point in looking at the brain. So we have seen cases of hypophysitis, where patients can have central adrenal insufficiency or other, central adrenal abnormality, central endocrine abnormalities due to hypophysitis or involvement of the pituitary with inflammation. Okay, so any other questions about immune-related toxicities? This is just meant to be an overview, but if you have any comments about things that you've seen or experienced with your patients. Okay. So there's still a lot of unanswered questions about how do we move the field forward with immune checkpoint inhibitors. We talked about how, we're trying to select patients who benefit the most, but patient selection, which we know is key, I think there's still a lot of work to be done in terms of which patients are really truly going to benefit from the immune checkpoint inhibitors, because PD-L1 doesn't tell the whole story. We've seen patients with PD-L1 negative expression that have responded, and we've also seen patients with very high PD-L1 expression who don't respond at all. So what is the optimal biomarker? So there are ongoing studies looking at that question. How do we monitor these patients more closely for some of these immune-related adverse events? So talking about the cardiac toxicities, right now the way the field is going is, should we monitor these patients more closely? Should we be checking troponins early on during the first courses of treatment to make sure that their heart is not being affected by this treatment? So those studies are ongoing. And then again, the sequence. What is the optimal sequence? Should we be combining these agents with chemotherapy, or should we be giving these agents in sequence? And we've also seen that with other immune checkpoint inhibitors, it appears that the sequence of the agents may matter in how we can sort of manipulate that immune response. And then what's the optimal duration of therapy? So right now, the way that we're giving these agents, the way they're approved, is you treat until progression. And I think there's a lot of studies that have shown, in fact, that perhaps you don't need that much immune checkpoint blockade. So in conclusion, cancer survival for advanced stage non-small cell lung cancer is expected to increase in light of these advances in immunotherapy. We've seen that there are 3 agents currently approved for second-line therapy: Nivolumab, pembrolizumab, and atezolizumab. And also that immunotherapy is moved for the frontline setting. So pembrolizumab, as well as pembrolizumab in combination with chemotherapy, are now approved in the frontline setting for patients with PD-L1 expression of 50% or greater, and also in patients with non-squamous histologies, regardless of PD-L1 expression. The side effects are generally mild and infrequent, and less than what we used to see with chemotherapy in the frontline setting or in the second-line setting. However, they do occur, and they can be serious and life-threatening if not identified and treated in a timely manner. One important thing is that multidisciplinary evaluation and management is preferred for patients who have severe toxicities, and treatment is based on the severity of the observed toxicity and requires use of corticosteroids. And in cases of corticosteroid refractory, they need to go on to additional immunosuppression. What choice of agent is still kind of in development according to the toxicity that we're seeing. Thank you. Any questions?
Hamid?
Yeah. So general symptoms of myocarditis would be fatigue, cough, shortness of breath, chest pain, and lower extremity edema. So sometimes it's vague in the beginning, but I think that that's why people are sort of advocating perhaps we need to be checking troponins, because there are some studies showing that if you see an elevation in troponin, even in an asymptomatic patient without any other explanation for that elevated troponin, that may be a marker or an early sign that you are getting some adverse effect on those myocytes. But certainly if patients start to develop symptoms, it really is important to make sure that you are checking that echocardiogram and seeing what's going on with that heart function, because frequently one of the manifestations that you'll see earlier on, they can be pretty vague. And when patients then are pretty sick, those are the cases that can progress very rapidly into fulminant myocarditis. We've seen patients with EF of less than 5% with life-threatening ventricular arrhythmias. Those are the patients that are in the cardiac ICU that need pacemakers. They need to be, supported for their EF and on aggressive treatment for their heart failure.
Yes.
One of the biggest challenges now with immune agents and their relative lack of toxicity is patient selection. I find that when I get to the GI cancer population, I'm tempted to use it because I feel the side effect profile much less, and yet we still have tons of patients getting admitted with very serious life-threatening toxicity. You have a specific algorithm that you would propose to remind oncologists who shouldn't be treated with these agents?
I think you bring up a good point. So, the studies, in general, they have excluded patients that have, performance status of 2 or greater. And in general, we know that older patients are excluded from clinical trials, or not excluded, but underrepresented is a better term for it. So how do we select patients that are borderline for chemotherapy, that we feel more comfortable giving immunotherapy because we know that in general it's well tolerated? Well, one of the things that I try to think about is the following. We know that in unselected patients, only about 20% of patients really benefit from these immune therapy agents. So not everybody really benefits from these treatments. And I also think about, well, what will happen if this patient has an immune-related adverse event? Can this patient tolerate a toxicity? Can they tolerate being on high-dose steroids for 4 to 6 weeks? And if the answer is no, then I would say perhaps that patient probably shouldn't be getting that agent.
Well, so you know what I'm going to ask, right? Because NIH is so interested in sex as a biological variable. Are there sex differences in those studies?
So, with what we've seen right now, we haven't identified that there are sex differences. That's a very good question, because when they went back and looked at the phase 1 Nivolumab study, they looked back and say, okay, let's study these patients who are alive and without progression at 5 years. Are there clinical characteristics that can sort of be a marker of how patients are going to do? And there was no clinical characteristic that they could identify, including a difference in sex. We know, from just the overall multiple studies that women overall actually do better than men in lung cancer, and that women live longer than men. So I don't know, there's something about the biology of lung cancer in women perhaps, or maybe women are less likely to be, in the past, active smokers. We don't really know, but women tend to do better than men and live longer with lung cancer.
Nan had a question. Okay. We need to repeat the question.
So that's an excellent question. So she's asking, what if a patient has... Yes, she's asking, what if a patient has an underlying immune disorder? Are they eligible to receive immunotherapy? Such as if a patient has rheumatoid arthritis, but they haven't had a flare for many years, or they have a history of Crohn's disease and they haven't had a flare for many years. And, again, most of these patients with immune suppression requiring treatment, or with a history of any immunosuppression, they were actually excluded from the trials. There are a few cases that, patients with Hashimoto's were allowed on the trials, with vitiligo, with psoriasis, but we do see flares. I think in clinical practice, people are doing it for those patients who don't have, a history of uncontrolled immunosuppression at this point. But we're also seeing that these patients flare, and they flare really badly. I mean, we've had patients with rheumatoid arthritis that come into the clinic and they say, I've read a lot about these agents. I really want to try it. We talk about the risks and benefits. Haven't had a flare for 10 years. And you start the PD-1, PD-L1 agent. And I had one patient specifically who had really debilitating flare of his rheumatoid arthritis. And he was bedbound until we started the steroids, and he responded within 24 hours. So it is pretty risky. And sometimes it's hard to have that discussion with the patient when they feel really strongly that they want to try it, but you have to tell them, this may put you in the hospital, and we can try it, but if you start to have that flare, you give me a call because we'll need to start steroids right away. So in general, in patients with active immunosuppression, I would not recommend, with the data that we have, starting them on PD-1, PD-L1 inhibitors off trial.
So I just have a question for you, Ticiana, about the EGFR mutated cancers. I mean, it looks like they were very underrepresented in the trials. So is the reason that you're saying, I mean, I know there's a toxicity issue here, but do they not have high levels of PD-L1? Is that why you're saying that, or?
No, actually, that's an excellent question. So there is a lack of data, because as you're saying, a lot of these patients were excluded from the trials. Some of the trials did allow patients with EGFR mutation, and then there's also sort of retrospective review from major institutions that treat a lot of patients with lung cancer. And sort of the thought behind why patients with EGFR or ALK rearrangements don't respond to immune checkpoint inhibitors really has to do with another biomarker that we're studying. A lot of these patients don't have high mutational burden. Their cancer really is driven by EGFR and ALK, and really they don't have, that high burden of neoantigens that we think is required for that immune response or that immune stimulation. So even in patients that have high PD-L1 expression in EGFR, I think the experience nationwide is that those patients tend to not respond, even with high PD-L1 expression. So there's something beyond PD-L1, and again, sort of the story is evolving, but looking at mutational burden as perhaps a better marker of response.
I know the other area that you're involved in is immunotherapy in small cell. Do you want to just briefly comment on that?
Yeah. So small cell is a disease that has a very poor prognosis, and really we haven't really made strides in the last 30 years in terms of how to treat and improve outcomes in small cell lung cancer. So small cell lung cancer, as you all know, is a disease that is very much associated with smoking, and that's also been a marker of high mutational burden. The studies that we've done with small cell looking at neoantigen and mutational load are showing that, yes, these patients do have a high mutational burden. So it really made a lot of sense to consider using immunotherapy in small cell lung cancer. One of the concerns is sort of the rapidity of the progression in small cell. Usually when we start immunotherapy, it takes about 6 to 8 weeks for patients to start to derive clinical benefit, whereas with chemotherapy, we generally see a quick response. But nonetheless, immunotherapy, not only as a single agent, but also in combination, Nivolumab and Ipilimumab are being actively investigated in small cell lung cancer, and so far showing promising results and showing, again, that durable response. So right now, even though it's not FDA approved, both Nivolumab and Nivolumab Ipilimumab are actually supported by our national cancer guidelines as a potential options for patients who have progressed through their frontline chemotherapy. And through ECOG, the Eastern Cooperative Oncology Group, we're actually investigating the combination of Nivolumab, which is a PD-1 blocker, in combination with frontline chemotherapy, carboplatin and etoposide, for patients with small cell lung cancer who have not received prior treatment. So we're hoping to open that study soon.
And you're leading that, right?
And I'm leading that study, yes.
Any other questions? Beniva had a question, I think.
So that's an excellent question. I think a lot of us were surprised by that FDA approval. So the question is, for patients in the frontline setting who have not received prior treatment, how do you incorporate the new data of that KEYNOTE 21 study that's looking at the combination of immunotherapy or pembrolizumab with chemotherapy compared to using pembrolizumab alone? And I think that's an excellent question. When the FDA approved that treatment option for patients in the frontline setting based on a small phase 2 study, based on progression-free survival benefit, which is basically, control of the cancer, but not survival. Did it extend survival? I think it was really surprising. We know that the toxicities are higher. And again, is it a sequence that matters, or is it really the combination? So, I've been a little reluctant to use it routinely for my patients in the frontline setting. It's especially difficult for the patients who have high PD-L1 expression, because we know those patients do so well on immunotherapy as a single agent. I really have been reserving the combination for patients with low PD-L1 expression or negative PD-L1 expression that are very motivated and can sort of understand the risks and benefits why we would choose one versus another. And a lot of patients actually try to stay away from chemotherapy. So it's a discussion that has to be really individualized.
One last question. Oh, here's trouble.
Thinking about
Yeah, so actually the question is, what about patient-reported outcomes? Have there been studies looking at, how patients are viewing immunotherapy and any quality of life or patient-reported outcomes out there? And in fact, there is. Julie Bramer presented this result of KEYNOTE 24, which investigated pembrolizumab in the frontline setting. And for patients who received pembrolizumab versus chemotherapy, there was overall an improvement in quality of life and patient-reported outcomes on the pembrolizumab arm.
All right, well, thank you very much.
You're welcome.